Morning, everyone. We're going to talk today about advanced lateral approaches. We have an affinity for doing lateral approaches here in Seattle, and we're going to present some very good articles. And first up is Dr. Richard Price from Washington University. Rick's going to show a case that we recently did, as well as talk about a nice article about corpectomies.
Hi, good morning, everyone. My name is Rick Price. I'm one of the spine fellows here. And I'll present the article first, and then I'll show the case afterwards. Okay, let's get started. I have the opportunity to present an article. Haley, it's not showing up on my screen now. I'll just look from up there. Yeah. This is an article that came out of UCSF by a electrophysiologist, and it's actually a friend of mine that we had an opportunity to overlap when he did his fellowship at WashU. He's back at UCSF now, and this is an anterior corpectomy via the mini-open extreme lateral transos approach combined with short segment posterior fixation for single-level traumatic lumbar burst fractures. It's analysis of health-related quality of life and patient satisfaction. The objective of this paper is to present clinical outcome data and patient satisfaction data for patients that underwent lateral corpectomy plus posterior spinal fusion, is what I'll refer to instead of all the jargon they use in the title from now on for lumbar burst fracture. A quick introduction. The traditional open approaches to the lumbar spine are associated with significant vascular morbidity, especially higher up at L1, 2, and 3. Major vascular injury, pulmonary embolism, ileus, postoperative hernias, et cetera. The first trans-psoas lateral approach was first reported in 2006, and then new innovation throughout the years in the interbody and then also lateral access technology, retractors, has improved the procedure and reduced morbidity. So methods, this is a retrospective study of cases performed at UCSF. There's 12 cases total from June 2009 to July 2013. And the surgical indications that they used for this procedure was lumbar burst fractures with either neurological symptoms, posterior ligamentous complex injury, and progressive loss of vertebral height or kyphosis after bracing. And then they did percutaneous instrumentation in the back, unless the patient had a neurological deficit or a vertical fracture through the lamina. And then if that was the case, it performed an open posterior spinal fusion with decompression. And then at 1 year follow-up, they queried the patients for ODI, SF12, and they use a SCAR-related questionnaire as well for quality of life. So diving into the patient data, they had 12 patients ranging in age from 23 up to, I think there's a patient in the 80s. And really the two things I want to bring your attention to is some of the complications that they experienced early on, where they had to do a revision surgery and then a washout. And then also around their fifth case, as technology improved, they switched from circular type cages to wide-based rectangular cages. It doesn't say in the article, but I presume that the number mechanism they use, 1 to 12, corresponds to the time frame of the patients, where 1 being the first patient they did and 12 being the last one. So this is experience with think patient number 2. This is an L3 burst fracture in a 68-year-old female with osteoporosis who fell down a flight of steps. In the top row, you can see the pre-op CT and MRI showing a burst fracture with retropulsion of the canal with significant canal stenosis here. They did a stage procedure where they did the percutaneous fusion in the back and then did a lateral corpectomy 2 days later. Fortunately, 2 weeks post-op, the cage had subsided as in panel F, so they took the patient back for a subsequent surgery, a T12 to L5 posterior spinal fusion with an L2 kyphoplasty. The patient did well after that. This is a case they did later in the series. think this was case number 12. And here you can see the use of a wide footprint. And this is a case that they had a success on with no revision or complication. And we'll go into the details of that. So this is some data, some of the intraoperative data, and then hospital data. They measured incision length, which is about 6 centimeters for the lateral access, which is considerably shorter than it would be if you did a large posterior fusion. A couple of things I want to point out. It was estimated blood loss was about 1,000 for this case, and I don't know if that was just the lateral portion or the posterior spine portion as well. That's quite a bit of blood loss, but I think that there was at least one case you can see here with a range of 3 liters that may have skewed the data a little bit. And the length of stay for these patients was rather long, at 18 days, but a lot of these patients were polytrauma patients, which explains some of the longer stay from this. Next, they measured lordosis, both focally at the level of injury and then total lumbar lordosis. And after the procedure, they had a significant increase in both focal lordosis and lumbar lordosis, and this was sustained through long-term follow-up at 1 year. Next in the paper, they did some quality of life measurements. I apologize for the text. Unfortunately, this is how it was presented in the paper. They didn't do this in a graphical form. The data was submitted by 11 patients at their 1-year follow-up. One was unhappy with their care and abstained from submitting any of their data. Their average ODI was 20. Their SF12 was 41.7, and their average pain of their scar was 2.6 on a 0 to 10 scale. But interestingly, 42% of the patients reported that the pain from the scar limits their ADLs. And then they asked the patients if they'd undergo the procedure again. 64% definitely would, and 27% probably would undergo the same procedure, the same approach, as opposed to an open posterior spinal fusion. So to discuss this paper a little bit, the patients are overall very satisfied with this minimally invasive lateral approach. There's no difference in self-reported outcomes when compared to open approaches using historical data, and it has better technology than plants have involved, so is their outcomes. And then overall, MIS lateral approach is a safe and effective alternative to open anterior approach for burst fractures. The limitations of this study is a small sample size, and there's no direct comparison to open surgery. And then finally, the fusion was not assessed by CT at 1-year follow-up. So that was the paper. I'll go ahead and present this case as a case Dr. Askew and I did about 2 weeks ago now, I think. This is a 71-year-old male, history of Paget's disease and osteoporosis, presented with low back pain. He got to the point where he had difficulty getting out of bed and walking upstairs, and then he denies any paresthesias or bowel bladder incontinence. He was neurologically intact. These are the plain film x-rays that shows at L4 a burst fracture. He has a good sagittal balance, and then here is good coronal balance. You can also see the fracture here at L4. The CT scan, you can see a lesion characteristic of Paget's disease with severe canal compromise. You can see here on the axial imaging. Furthermore, you can see on the MRI where significant canal stenosis, where you can barely even see the spinal cord. And this isn't projecting very well, but this is pre-contrast T1 sagittal and post-contrast as well, showing a little bit of contrast enhancement there at the vertebral body affected by Paget's disease. So our operative plan, we did this in a 2-stage approach, similar that they did in the paper. Because the canal was so compromised, we did an open approach with laminectomy at L4 and then a posterior corpectomy to free up the ventral portion of the thecal sac. And then stage 2 was a lateral L4 corpectomy that we did left side up. Case went very well. This is our postoperative films. As you can see here on the right side, we used a wide base rectangular footprint. Patient did well after surgery. If I can recall, I think he left on post-op day 2 to home. And just we have a little bit of time, just quick learning slide on Paget's disease. So disturbance in bone remodeling due to upregulation of osteoclastic activity, which ultimately results in brittle bones, which can lead to pathological fractures. And here on the right, there's several mechanisms of Paget's disease. The first one is, I'm having trouble seeing this because it's not on my screen, is a periosteal apposition with a normal endosteum with below the representative figure, what it looks like. In our case, it was more like figure B with periosteal apposition and endosteal resorption. Other mechanisms down here is periosteal apposition, endosteal apposition, and then this pumice stone type formation with just focal periosteal apposition. That's all I have. I'll take any questions on this paper. Do you have any comments about the case?
Can I ask you a question, guys? What's the algorithm for treating massive blood loss through an MIS extreme lateral approach? You know, if you're looking at 1,000 cc pouring out of a hole.
So I can answer that. It depends if it's venous or arterial. If it's arterial, usually one of the first things that we do, and Dr. Price showed an excellent case, we identified the segmental artery and then coagulate it. And during that case, we found we had a very large segmental. So, if it's venous, typically it's from cancellous bone, or you can get some of that. Like in this case, we went posterior first and coagulated the epidural veins. If it's, venous, just like any other open corpectomy, we use hemostatic agents. I don't know why. They might have had a vascular injury. I mean, 3 liters of blood is a little bit over the top, I think. So I'm not sure that was necessarily, commonly, maybe I'll lose 400, 300 cc's at the most. So blood loss really isn't an issue.
Yeah, but with an acute fracture ride, you can have bleeding from the exposed bone, but you can also worry about a vascular laceration that from an anterior approach, you might be able to get control of. Wonder from a lateral approach, how much you can really mobilize a vessel or try to do a vessel repair or ligation from that window.
Yeah, you really can't. That's a good point, Jack. We, knock on wood, we haven't really had experience too much with. Now, if you're doing ACRs and some of the other techniques we're going to talk about, then yeah, having access to the vessels certainly helps, and it can pose a significant risk if you do have an injury. So we're going to move on. We have Dr. Nuna. Thank you, Dr. Price. So Dr. Nuna is from Chicago, and he's going to discuss a very nice article as well. So Ravi, come on up. And what's interesting to me is how, I remember doing these surgeries back in 2006. It's incredible how between the instruments, the neuromonitoring, and the implants have evolved so much just in the last 5 years in particular. So you can do a lot doing lateral surgery. So, Ravi.
Thanks, Dr. Osquin. So staying along with our topic on advanced lateral techniques, I'm going to be presenting an interesting study out of JNS Spine published in 2018 out of the group in UCSF and some colleagues in Seoul, South Korea, titled Comparative Analysis of 3 Surgical Strategies for Adult Spinal Deformity with Mild to Moderate Sagittal Imbalance. Just a little bit of background information. Adult spinal deformity has varied treatment options depending on the patient's baseline condition. Generally, the goal of surgical treatment for patients with ASD is to achieve sagittal and coronal balance, relieve axial and radiating pain, and achieve fusion. Inner body fusion has been advocated as an important surgical option in the treatment of ASD because it can increase disc height, indirect decompression of the neural foramen, enable circumferential fusion, and it also increases lumbar lordosis. As we all know, there's many different techniques for inner body fusion. We have the posterior techniques, we have a lateral technique, as well as anterior inner body fusion. Now, patients with decompensated rigid deformities, such as those with severe sagittal imbalance of greater than 10 centimeters, often require a 3-column osteotomy. However, those with mild to moderate global sagittal imbalance, or SVA, less than 10 centimeters, may be treated with highly varied techniques dependent on surgeon preference. Now, the aim of this study was to investigate and do a closer inspection of this specific patient cohort. So the aim of the study was to evaluate the effectiveness of different surgical strategies in the treatment of ASD in patients with mild to moderate sagittal imbalance, or more specifically, less than 10 centimeters. They analyzed radiographic data, complication data, as well as health-related quality of life outcome scores among these patients who underwent surgery. This was a retrospective single institution comparative cohort analysis performed over a decade, 2003 to 2013. Inclusion criteria included all adult patients diagnosed with ASD, including pelvic fixation to upper instrumented levels at L1 or above, an SVA of less than 10 centimeters, a minimum 2 years of follow-up, and at least one of the following: of a coronal Cobb angle of greater than 20 degrees, a pelvic tilt of less than 20 degrees, or a pelvic incidence and lumbar lordosis mismatch of greater than 10 degrees. They excluded all patients with severe sagittal imbalance, patients that underwent a 3-column osteotomy for scoliosis correction, any deformity related to infection, and all patients with any kind of malignancy. There were 3 surgical groups. The first surgical group was posterior spinal fixation only, or posterior only approach. Second group was a lateral plus a posterior group. And then the third group was an anterior approach plus the posterior approach. Now, notable is that the lateral group actually included patients that underwent a 5-1 TLIF. So essentially all the patients that we see in group 2 actually also underwent a TLIF at 5-1. Surgery was generally performed in the traditional fashion in all 3 groups. Nothing notable in terms of their surgical technique. The groups were generally well balanced. There was 221 total patients. The largest group was the ALIF plus posterior group. Some interesting things to note here was that the ALIF patients were generally younger and that they had a lower BMI, which is unsurprising given the contraindication of morbid obesity to an anterior approach. In addition, lateral patients had the highest number of mean interbody fusions. Beyond this, the groups were very well matched, especially in terms of spinal parameters. So we won't go through the entire list of outcome data in terms of sagittal and coronal radiographs. However, they were all essentially not statistically different between all 3 groups, essentially throughout all parameters. However, the only difference was that those in the lateral group actually had the PGA, the proximal junctional angle, was significantly lower in the lateral group versus the other groups. This is really the only difference. Surgical complications were generally also equivalent between the groups. However, the lateral group had a lower incidence of PJK, 22.4% versus 41.8 in the posterior group, lower rate of upper instrumented vertebral fractures, 13.8 versus up to 30% in the other 2 groups, and lower rates of upper spondylolisthesis, 0% versus about 5 to 7% in the other groups. Revision rates were essentially equivalent between the 3 groups, as well as rates of hardware prominence and other perioperative complications were also similar between the groups, including any kind of neurologic injury between the groups. Outcome measures included VAS back, VAS leg, ODI, many different components of the SRS-22 questionnaire, as well as short form 36. The lateral group for this analysis was associated with a greater increase in final SRS-22, showing a 46.3% increase versus other 2 groups were between 20.3 and 26%. And the lateral cohort was also associated with a greater reduction in disability, or ODI, showing up to a 40% reduction in ODI versus between a 15 to 25% reduction in the posterior and the anterior groups. So ultimately, the primary conclusions for the study were that all three different surgical strategies can adequately result in correction of sagittal imbalance in those with mild to moderate sagittal deformity. In addition, that there were essentially similar complication rates between these three groups. However, the most interesting finding of this study was that the lateral cohort actually had lower rates of PJK and mechanical failure at the upper instrumented levels, less back pain, less disability, and better SRS 22 scores. These authors included a short discussion of some of the surgical considerations in these different surgical techniques, including that the posterior-only approach, as previously shown in the literature, results in adequate correction. However, it has been shown to sometimes be associated with greater morbidity, as well as having less access to the anterior column. For instance, in this group, there were only 16% of the patients in the posterior-only approach had interbody fusions. The ALIF allows for wide discectomy, 5-1 access. You can resect the ALL. There's less psoas retraction, and however, there is a risk to the abdominal viscera and the vessels. In the lateral approach, you're able to restore disc height. You can have an indirect decompression of the foramen. You can preserve the ALL and PLL, and you can use wide interbody cages. They also compared and contrasted to a couple other studies that also came out of the UCS group. Hack et al. Found that in 2014 found that the lateral was associated with greater restoration of PI lumbar lordosis mismatch, as well as SVA versus a posterior approach. And Hamilton in 2016 found that the lateral was actually associated with lower rates of SVA correction. So just showing that, a lot of these different studies and groups have shown conflicting results, and that obviously we need further analysis of these kind of patients to ultimately show what the best course of action is.
Thank you, Ravi. Did the authors use a oblique anterior interbody fusion approach for 4551? Did they specify that was a traditional anterior interbody fusion?
It was traditional anterior interbody fusion. There was no oblique lateral interbody fusions performed for all three cohorts.
Yeah, Dr. Dekotowski has been really good at texting throughout. Hello, Mark from Seattle. We miss you here. Got to get you out to one of our meetings again. So this is, again, obviously more a case series with an extensive kind of access to outcomes data. And again, a lot of inferences are drawn from a pretty limited follow-up. So again, the important thing is that in general hands, it seems to me that an anterior column restoration is desirable, and that anterior approaches, as long as they're done safely, probably restore lordosis more. Is that a safe kind of a conclusion to draw from your end?
Logically, that would be a safe conclusion to draw, but interestingly enough, the posterior group actually showed the same rates of correction in terms of lumbar lordosis in these studies. So they may be indicating that, perhaps anterior column access is not as important. However, the outcomes were better for the lateral and the anterior group.
These numbers, while in general high-looking, like 220 patients overall, were split into three cohorts. Was there ever a power analysis? The reason why I'm saying that is that there's a huge amount of overlap of the numeric data, which leads to a strong suspicion that this study is actually crassly underpowered.
No power analysis was performed in the study.
Just again, this would require a more detailed assessment, but just as I'm looking at this data sheet, I have a strong suspicion that this study is actually underpowered and therefore not really able beyond the ubiquitous P level to draw any form of real conclusions.
Right, and definitely I think the case numbers are, a huge limitation in the study.
Terrific, Ravi.
Quick, one more question. Tarek Radwan, hello to New England from your friends in Seattle. Tarek was asking, what was the longest follow-up, and has there been a difference in hardware failures if you look at posterior only versus anterior and posterior reconstructions in these patients?
So this study had a minimum of 2-year follow-up. I'm not sure if they specified the longest follow-up, but any patients with less than 2-year follow-up were excluded. In terms of hardware failure, this study actually showed that the lateral cohort had lower rates of hardware failure, lower rates of fracture at the upper instrumented levels, and lower rates of PJK. However, higher rates in the anterior and the posterior only approach.
Thank you.
Terrific, Ravi. So our next presenter is Dr. Elias, who's spending the year with us. He's from American University in Beirut. In fact, he was on my service. We did quite a few lateral cases, and he's going to go back to Beirut and do lateral surgery. So, Elias.
Can I just hit F5? So good morning, my name is Elias. I'm a neurosurgeon from Beirut, Lebanon, one of the spine fellows here in Swedish. So today I will present this paper. It's entitled Prelim Results of ALIF ACR for the treatment of sagittal malalignment. It was published in Neurosurgical Focus in 2017 by Purya Layumi et al. From San Diego Spine Foundation. So a little bit of introduction. So the authors described the importance of correction for deformities and how the severity of symptoms will increase in a linear fashion if the sagittal malalignment is not corrected. Hence the importance of the restoration of the sagittal balance, which is directly linked to satisfactory post-op surgical outcomes. They went on to describe the importance of the variables regarding the realignment, regarding the PT, the SVA, T1 spinopelvic inclination, LL pelvic incidence, and they stated that these numbers, they vary with age. So they are not fixed numbers, and there is a difference between a young patient and an old patient. Then we have the posterior approaches, which are mainly, they mainly include the osteotomies for severe kyphosis. And these approaches will have longer uptime, more neuro complications, and higher volume of blood loss. So they use the ALIF ACR as an alternative for the posterior osteotomies, especially for the lower lumbar segments. And they mentioned that the ALIF can be used to access mainly the L5-S1 area and the L4-L5, since the ALIF cannot be used for this lumbar level, for restoration of the lordosis. So their aim was to evaluate the clinical and radiological outcome with the ALIF ACR for the patient they included that have sagittal plane spine deformities. So this is a retrospective study. It included, so initially they had 50 patients that were treated with ALIF between 2013 and 2015. Inclusion criteria was any patient who had ALIF, who had radiographic follow-up for 1 year at least. However, they ended up with only 39 patients. 11 were excluded due to missing radiographic data. So they included different variables, including demographic and the length of hospital stay, complications, number of ALIFs. And then they went on with to describe the surgical technique of the ALIF, including vascular access, anterior retroperitoneal approach, all the way to implant placement and securing it with vertebral body screws. Then they assessed the typical radiographic parameters that I spoke about earlier, and they assessed the fusion rate while using the Lenke classification. So grade 1 and grade 2, mainly you have good fusion rate. Grade 3 and grade 4, we have lucency, and you have absence of fusion with collapse. So also regarding the outcomes, they used the VAS, the ODI, and the SRS-22. And the complications, they were grouped into major and minor complications based on the Schwab classification. For analysis, they used the SPSS-23, and p-value less than 0.05 was used as significance. So regarding the results, so they have a total of 39 patients. Mean follow-up was 13 months. Mean age was 66, and mean BMI was 27. They had a total of 60 ALIFs included for the 39 patients. 46% of the 39 patients had one level ALIF, whereas 54% had two levels ALIF. So 60% of those patients had L5S1 ALIF, and 40% had L4, L5 ALIF. 73% of the patients had posterior spinal fixation in addition to their anterior approach, and 27% had standalone ALIF. The mean hospital stay was 7 days. And so regarding the radiographic parameters, SVA, PILL difference, IDA, and MSA were significant at 3-month post-op and 1 year post-op. And regarding the outcome measures for the VAS, ODI, and SRS-22, also patients showed satisfactory outcome at 3 months and 1 year follow-up. 95% of the patients had good fusion, mainly grade 1 and grade 2 Lenke classification, and only 5% or 2 patients had grade 3 or no fusion, grade 3 or grade 4 fusion. So 14 patients or 36% had complications, and 11 patients required reoperations. So but the author, they didn't specify reoperations. What's the real reason of the cause of the reoperations? And most common complications were PJK and followed by vertebral body and plate fracture. So neuro-wise, 15 patients had abnormal lower extremity sensation, and all those 15 patients had resolution of the paresthesia after the ALIFs. 10 patients had abnormal lower strength pre-op. 7 patients recovered their full motor power post the ALIF. So they went on and they discussed the importance of ALIF regarding the radiographic parameters and how they improved from pre-op to post-op, and how the VAS, ODI, SRS also improved after the ALIF, and how they had like 95% fusion rates using the anterior technique. And they compared the result or the complication mainly versus the lateral approach versus the LIF. They also compared the reoperation versus LIF and the literature, and the correction rate versus LIF, and different literature reviews. However, this paper has some limitations. So the fusion grades that I spoke about, grade 1, 2, and 3, 4, was assessed using X-rays, since not all patients had post-op CT scans. They didn't have the smoking and the bone quality status of every patient. This paper is retrospective in nature. The sample size is 39. It's not that big. And they didn't stratify the ALIF levels with the type of complications. So they didn't go on and describe how many levels for ALIF was associated with what complication. In conclusion, so they concluded that ALIF is a viable option for realignment technique for sagittal plane deformities, and they emphasized the importance of ALIF, especially in in the lower lumbar area over L4, L5, and L5S1 compared to the LLIF approach. Thank you.
That was terrific. Purya, can you go back to, so I just have, there's a couple questions. The first one is, what do you mean by ALIF ACR? Can you define? Is this a traditional ALIF, but then they're trying to go back and posterior? Or is this a lateral
No,
ACR?
Yeah, so in their paper, they described that this is the second paper that describes the ALIF ACR, but I think from the surgical technique description, this is a typical ALIF
Exactly. So that's
approach.
why I wanted you to talk about it, is this is a traditional ALIF that they're doing, but then they're going posterior, taking the PLO.
Exactly.
Going lateral, getting circumferential, decompression and releasing.
Dissecting everything.
Yeah, exactly. Any other questions from the audience? That was a terrific presentation. So are you going to do ACRs when you get back to Lebanon, or are you going to do lateral?
I think I will do lateral.
Okay, that's a good answer.
Yes.
But I think for 5.1 and 4.5, you can get a lot of correction. I think there's some advantages to going anterior. I don't know, we'll have to do a journal club on oblique, but, there's this controversy now, is do you go lateral or oblique? But I wanted you guys to review some of the older literature, so thanks, Elias. Great. So our next presenter is actually the real Purya. I don't know if you guys saw, but the last author was Purya Husseini. So we have Dr. Purya Layumi, who is one of our outstanding fellows from USC. He's actually originally from Tehran, so we recruited him from Iran via Los Angeles. And he's spending the year with us here. And his father is actually a very well-known orthopedic surgeon in Tehran, so I'm hoping that his dad is logging in to watch him. Put a little bit more pressure on Purya. So Purya is going to talk about a very interesting topic, which I think actually this is one of the things, this is why when Dr. Ziegler and Geyer asked me to talk about lateral, one of the things I've noticed, and I know the fellows as well, we kind of talked about it, is there's kind of a lack of literature on complications. And I love our societies and our surgeons, but I think when you underreport complications, it actually hurts us. So Dr. Layumi is going to present about there's a paper on complications that was published. Purya.
Awesome. Thank you, Dr. Roskrian. Good morning, everyone. My name is Purya Layumi, one of the fellows here at Swedish. The article that I'm presenting is Intraoperative and Early Postoperative Complications in Extreme Lateral Interbody Fusion. It was published in 2010 in Spine, and the senior author was Dr. Rogers. In terms of background, my co-fellows did a nice job going through the background of what XLIF is, so I'm not going to spend too much time on that. But prior to the publication of this study, there was basically one other article with 58 patients that reported on complications, and that was published by King. So in terms of the goals of this article, it was to evaluate the intraoperative and early postoperative complications in a large series of XLIFs done. And it was a retrospective review of a prospective compiled database by the senior author. In terms of methods, they had every patient that underwent XLIF starting from 2006 up until the publication of the article. They excluded all neoplastic, traumatic, and infectious cases and only included degenerative disease. Early postoperative complication, they defined it as within the 6 weeks from the index surgery, and they divided up the complications into surgical versus medical, and also subdivided the medicals into based on the systems involved, and they used multivariate logistic regression using multiple factors as listed. In terms of demographics, they had 600 patients that underwent XLIFs within that time period. Majority of them were single levels. They did posterior instrumentation in 511 of those of the procedures, 84 lateral fixations alone, and 5 of them with no additional stabilization. 40% had prior spine surgery, as shown in that chart on the side. In terms of results, they had a total of 37 complications. 60% of them were medical and 40% surgical. The perioperative complications, including intra-op plus 6 weeks post-operatively, was only 6.2%. They had no infections, no vascular injury, and no injury to viscera at all. They had 4 neurological deficits post-operatively. 3 of them were quadriceps. 1 of them was tibialis anterior weakness, and all of them resolved within 3 months. And complications did not affect pain score improvement and patient satisfaction based on the report. Comorbidities also were not predictive of the type of the incidence of complication. Prior surgery, however, was associated with increased risk of complication in these patients, and also number of levels involved in the XLIF procedure was associated with complications, and inclusion of L4-5 was associated with neurological injury. Actually, senior author, after having a few neurological injury doing L4-5, he started using dexamethasone 10 milligram IV in all XLIFs involving L4-5, and he reported that after that he had no neurological injury. However, this did not reach statistical significance. Average length of stay was 1.2 days, and 11 patients required reoperation, and they mentioned that thigh pain and hip flexion was essentially universal, however, it was always transient. And in terms, 90% of the patients reported satisfaction overall with the procedure, and mentioned that they would have the procedure again. This was the table that they included in the article, and as you can see, they break down all the complications involved, and the patients that required reoperation mostly was due to either implant or bony fractures, and there was 1 patient that had a hematoma that required IND. In terms of strength, it's a large series, and it was the first large series at the time evaluating complications of XLIFs. They did a very nice job, a kind of comprehensive review of all the medical and surgical complications. Weakness, if I had to pick one, was aside from VAS and patient satisfaction, they did not include any other PROs, but again, the main goal of the study was to report on the complications, and I think they did a very nice job with that. So in conclusion, again, a large study, comprehensive review of complications. In the discussion, they did a really nice job not only comparing XLIF complications with the prior study, but also comparing it with other approaches and other studies, and they reported that complications were fewer and less serious. Length of stay was less, about 1.2 on average, and patient satisfaction was pretty high with this procedure. Thank you.
One quick question, if I may, Purya.
Yes,
so
sir.
thank you for bringing up complications. This is obviously an older paper. Was there differentiation made between revision surgeries and de novo surgeries? And was there a difference made in terms of upper versus lower lumbar spine using L3 as a gradient? Hypothesis for the latter question being that lower lumbar spine has a higher complication rate. Hypothesis for the prior being revision surgeries in any way, shape, or form that had some previous abdominal procedures are higher.
So they did mention that patients that had prior surgeries had a high rate of complication. At the time of XLIFs, they did not break down based on number of levels. However, all the neurological deficits that they had involved L4-5, as you mentioned, and that's why they started including using dexamethasone.
And then, Purya, can you go back a couple slides?
Absolutely.
So what I found interesting with this is that they also talked about medical complications.
That's right.
But, which, again, it's fine I think it's good to report that. But in my experience, go back some more, they had a very low, right here. So, my complication rate, honestly, every patient that I do a lateral on, especially in L3-4, L4-5, they all wake up with, you're going through the psoas. So usually if you have, they all wake up with thigh, their numbs are, their thighs are numb. They have hip flexion weakness. They have thigh pain. All my patients are put on Neurontin. So even though it's transient, it usually lasts for 6 to 12 weeks. I think, when you look at the literature, there's kind of people don't really talk about it much.
They did briefly mention
Yeah.
that thigh pain and hip flexion was essentially universal.
Yeah.
And it was always transient.
Yeah.
But the main neurological injury was kind of quadriceps and L4 nerve root that they reported as major neurological deficit.
Right.
Yeah.
So, great. Thank you, Purya.
Awesome. Thank you.
Hey, Rod,
Yeah.
and you're very honest in telling your patients, but what percent will get functional weakness? And granted, it's transient, but will have difficulty walking.
So that's a great question, Rick. I think it depends on, obviously if you're doing a corpectomy at L4-5 versus just a lateral, I think in my experience, if you're doing multi-level deformity correction and corpectomy, they all wake up a little bit weak because you can imagine you're going in and out, retractor time is an issue. And so, I universally kind of tell them, and Jens and I do a lot of our complex deformities in stage, they all wake up with a little bit of weakness. But if you're just doing a kind of a bread and butter one level, those patients, it's a totally different operation. So,
But, I think the important thing that you said is, I think it's preparing the patient of the expectations that you are going to have some, maybe a little weakness, you're going to have some numbness, you're going to have pain there. And I think in our practice, we do the same thing. We try to prepare them for everything and tell them that it's normal. And, as you say, it might take 6 to 12 weeks to get better.
yeah, I think that's an important part of our preoperative education is kind of going over that, because then, one of the things that if they expect it, then it's fine. But if they're not expecting it, they'll definitely be, they'll not be happy.
And what doses of Neurontin do you put them on, Rod?
I like 900 milligrams at night because it doesn't, it tends to make them kind of sleepy. And then if we need to go up on it, we'll go up on their doses during the daytime. And we've tried dexamethasone. It doesn't do anything. I think it makes you feel better, but in our experience, it really doesn't have any, doesn't reduce your nerve injury rate. So, okay, so we're gonna push forward. Our next speaker is Dr. Sven Friel from Bochum. He's spending the year with us. He's our research fellow. He's doing a terrific job. He's published numerous papers. He's writing now some very seminal articles on lateral surgery, deformity correction, and he's going to go back to Germany in January, and we've really enjoyed working with him. So I thought he would talk about a new craze that's going on right now where, just as soon as you think they're done with doing a lateral, people have now come up with the prone transpsoas approach, which I think is fascinating. So Sven is going to talk about that, and the acronym has changed. It's not XLIF, ALIF, LLIF. It's called Ptp. So Sven, take it away.
Thanks for the warm introduction, Dr. Oskunian. My name is Sven Frieler. I'm a research fellow here at the Swedish Neuroscience Institute. I'm originally from Germany, where I'm a resident at the University Hospital Bergmannsheil Bochum. And today at our journal club, I'm presenting the prone transpsoas technique preliminary radiographic results of a multi-center experience. The article was published in the European Spine Journal this year. The purpose of the study was to evaluate a new approach to the lateral lumbar interbody fusion to solve or at least to reduce some unsolved problems regarding the standard LLIF, which we will briefly discuss on the following slides. The principal difference from the standard LLIF relies on the positioning of the patient in a prone decubitus to increase the interdiscal lordosis. The report summarizes the radiological outcomes of the initial clinical experience of the prone transpsoas, or like Dr. Oskunian mentioned, the Ptp approach. Generally speaking, minimal invasive techniques have become more popular, aiming to reduce the extent of surgery, amount of blood loss, length of stay, and recovery time. One of those less invasive techniques is the LIF, initially described by Luis Pimenta. The LF is a good option for interbody fusion as it reduces posterior muscle damage, is capable of relieving neurological symptoms through indirect decompression, provides increased stability with its wider cages, and promotes more significant gain of segmental lordosis than, for example, standard posterior techniques. Nevertheless, LIF's procedures also has its limitations, such as post-operative neurological deficits, small segmental lordosis improvements, and the necessity to reposition the patient to instrument posteriorly or to perform direct decompression when needed. The loss of segmental lordosis is an important factor in the cascade of decompensation. Several aspects of correction have been studied to understand which factors are associated with segmental lordosis after interbody fusion, such as cage angle, posterior osteotomies, ALL rupture, and cage positioning. As mentioned in the introduction, the new approach aims to reduce some of these problems by positioning the patient in a prone decubitus, which might improve the intradiscal lordosis. Okay, let's move to the methods. It was a multi-center clinical trial. It was a retrospective reviewed to measure sagittal spinopelvic alignment from paired pre-operative and post-operative radiographs. In more detail, they measured the index level segmental lordosis, the total lumbar lordosis L1 to S1, pelvic incidence, and the pelvic tilt. This picture demonstrates the setup for the Ptp approach. The patient is positioned prone over a Jackson table with the abdomen hanging freely. Preferable, the used table should allow some rotation. Access to the anterior column then follows in the standard lateral approach fashion with a carefully dissection into the retroperitoneal space and using EMG feedback advancing transverse to the disc surface. The retractor plates are opened no larger than end plate to end plate in the craniocaudal direction, and an anterior blade is introduced to retract the remaining anterior tissue to allow the disc preparation and cage placement. The interbody work is possible in a seated or in a standing position, depending, of course, on the surgeon's preference. Followed by a standard layered closure. Posterior fixation or direct decompression, if needed, could be performed without the necessity of repositioning the patient, and the procedure could also perform simultaneously with the lateral approach in this position. To the results, 32 patients were included, 56% of them were female, and the mean age was 64.3 years old. 23 patients underwent 1 level, 6 patients underwent 2 level, 2 underwent 3 level, and 1 patient underwent a 4 level PTP. The mean surgical duration was 179.4 minutes with 187 milliliter estimated blood loss and a mean 2.4 days of stay. 6 complications occurred after the procedure with 4 post-operative neurological deficits. All of them recovered at a 6-week follow-up, 1 psoas hematoma and 1 durotomy. The mean index level segmental lordosis increased from 8.7 degree preoperatively to 14.8 degree postoperatively, resulting in a 6.2 degree segmental lordosis gain with a p-value of 0.001, which is demonstrated on the first picture. The second picture shows that the lumbar lordosis L1 S1 increased from 42.1 degree to 45.8 degree. And actually, after excluding an outlier value, the lumbar lordosis was 41.9 degree preoperative to 46.7 degree postoperative with a p-value of 0.003. Initially, 22 patients had a pelvic incidence lumbar lordosis mismatch of 10% or greater, and postoperatively only 12 patients still had this mismatch, which is illustrated in the first picture on this slide. The second picture shows the pelvic tilt with a reduction from 20.8 degree preoperatively to 80.5 degree postoperatively. A mean reduction of 3.2 degree was achieved. So first, the discussion was facing the reason for developing a new approach and not comparing results to other techniques. The LF is an established surgical procedure that has been well described in the literature as an option to treat a wide range of spinal pathologies. The technique relies on indirect decompression and excellent stabilization of the index level, addressing both the neurological and the mechanical symptoms of the patient. The most important limitations of the LF are the necessity to reposition the patient to perform a direct decompression or posterior fixation, and the only modest segmental lordosis. Miyazaki et al. Demonstrated in 2019 that patients who underwent a TLIF on a Jackson table in prone decubitus had a significant increase in L4, L5 segmental lordosis intraoperatively and at a 2-year postoperatively. This result led to the hypothesis of this study that PTP can produce a considerable amount of segmental lordosis gain without the use of ALL release or other techniques. Also in 2019, Sino et al. And some of other authors showed that patients undergoing a lateral then prone reposition did not present significant changes in lumbar lordosis when compared to patients receiving a single lateral surgery. Both observations resulted in 2 basic ideas. First, prone position setting may increase segmental lordosis. Second, receiving the interbody fusion firstly may influence the biomechanical behavior of the spinal function unit and decrease the possibilities of enhancing the segmental lordosis after flipping. The results of the current study suggest that prone transverse PTP technique is not only feasible, but it's also associated with a significant gain of segmental lordosis and correction of other spinopelvic parameters. Thanks very much.
Terrific, Sven. Just in time for maybe 1 or 2 questions from the audience. I think it's interesting, if you think about basically the main reason that they're saying you should do prone transpsoas is that you don't have to reposition the patient.
Exactly.
And that by putting the position prone, that you get more lordosis. So I think it's reasonable, and I think the only thing I see is that I don't know if anyone's ever tried to do a lateral prone, but it's for the surgeon, it's technically very demanding.
So quickly, Mark had a couple of important aspects. He does, I think, rightly point out that 4, 5, and below should be looked at separately, specifically for 4 or 5 far lateral approaches. Retractor time and plexus injury potential is much higher. So thank you, Mark, for that. And using live EMG and limiting retractor time is another factor. And again, a lot of credit goes to Dr. Pimenta for having commercialized the transpsoas approach, but this has actually been around for a long time. The big question is, who does it really help to do a single-stage front-back surgery? Is it truly the patient, or is it the surgeon convenience? So I'll leave that open in the area. We're at the end. Texas, do you want to take us out of here? Maybe Izzy has been quiet.
Well, Jens, I just want to thank Rod and you guys. You did a great job, and it's an interesting area that is becoming more and more popular and is very, very powerful in our armamentarium. So thank you very much. Everybody stay safe, and we'll see you next week.
Okay.
Thanks. Have a good weekend. Thanks, Izzy.
Have a good weekend, everybody.
Texas back guys are so good. I really like them a lot. Yeah.
All right, who's running this show?
Okay.
Thank you.
Who's the
Thanks for watching. Hit the subscribe button for more medical content.